All right. Welcome, welcome. So today we're going to finish out our understanding of the blood. Looks like we actually will get through all of this. Might be a little bit of a light day today, but I know we've got kind of some chunky topics here. So we'll spend some time reviewing things on Monday before your exam on Wednesday. Although if people don't have questions on Monday, we might break into a little bit of the respiratory anatomy, just so that we can talk about some of that from a physiology perspective to pair up with your labs, since I know you've been seeing lungs this week and I'll see more of them next week. Okay. So we left off introing our final topic, which is what we do when blood vessels get injured, basically. So we talked about our vascular spasm, which is our kind of fastest response in when we damage a blood vessel, and we start to clamp down that blood vessel immediately so that we reduce the blood flow there. So part of that's from the blood vessel itself as an intrinsic response. And usually you've got some sympathetic innervation at the same time. And then we mentioned that our next bit is dependent on our platelets. So our platelets, sort of a form of like a fragmentary, let's say, white blood cell, because it does have these granules that are going to produce secretory products that we'll talk about in a second. Okay, so this is our first new bit. So this is a kind of flow chart of what happens as we try to form a platelet plug. So this is our first step to trying to actually close the gap where we have an injury. Okay, so when you damage a blood vessel, we want to think about what happens, like what that exposes the blood to. So we'll see when we get to actual blood clot formation that we want to realize, right, you're probably damaging some other tissues as you're going from the outside to the inside. So some tissue surrounding that blood vessel is probably damaged. And then the blood vessel itself is also experiencing damage. So this means that your blood is able to touch all sorts of things that it's usually not able to come into contact with. So this blood vessel damage is going to expose what we refer to as the subendothelium. So remember, the endothelium is that inner layer of our blood vessel. So subendothelium is just going to be like the next sort of deeper layer from the perspective of the blood. So like the next layer out. And we'll have a picture in a second. Okay. So when we expose this new layer, the subendothelium, things in your blood start to act differently. Okay. So you have lots of different proteins swimming around in your blood all the time that could form clots, but don't. So we're going to get into how those things get activated to form clots. One of those substances in your blood is something called von Willebrand factor. It's going to play a couple different roles in this hemostasis process, but this is the first one. So when we expose that subendothelium, what we're partially going to be exposing in that layer are collagen fibers. So collagen fibers are, we thought about collagen in the context of like connective tissue, but we got collagen in the blood vessel walls as well. So von Willebrand factor, when it comes into contact with those collagen fibers, binds to it. So it's not swimming just freely through your bloodstream anymore. It's contacting the collagen fiber and sticking to it. And this is what gives a signal to the platelets to also start to stick to that damaged blood vessel wall. So when we think about the platelets, we can think of them as being kind of activated by this von Willebrand factor, right? And that's going to tell them to adhere to the vessel wall. So platelet adhesion is just them sticking to the blood vessel wall, adhering. Okay? The platelets are secreting all kinds of things that we'll talk about in a second. Some of those things are making the platelets kind of sticky, and the von Willebrand factor is also making our blood vessel wall kind of sticky, which is ultimately going to cause more and more platelets to stick to this spot and to stick to each other. Okay. So we got a cut. We expose the subendothelium, and specifically it's collagen. Von Willebrand factor binds in there, and then platelets start to adhere to that spot where we've got the von Willebrand factor. So then our next step is making this platelet plug bigger through the process that we refer to as aggregation. So aggregation is just, a fancy word for grouping them together, right? So our platelets are aggregating together, clumping up, and that clump of platelets starts to release secretory products. So like we had granules in the platelets, they can make stuff. So secretions are just things that are coming out of the platelet, getting onto the surface of the platelet, and getting into the local area around this platelet plug we're forming. So a couple of the things that they're secreting, ADP is a molecule that increases how sticky these platelets are. So this acts as like a positive feedback loop because these platelets stuck to this area of damage. They're a little bit sticky. Couple more platelets stuck in there. Now they're secreting this ADP. They get even stickier. So we get even more platelets aggregating in this area. The platelets are also secreting some serotonin and some epinephrine. We talked about epinephrine in blood vessels before, but serotonin acts in a similar way, causing vasoconstriction. So before we made the platelet plug, we had a vascular spasm constricting this blood vessel down. Now our platelets are telling that blood vessel to keep constricting, do a little more constriction. We're still trying to really limit the flow to this area. Okay. So that's what our serotonin and epinephrine are doing. And we also have some signals coming from the platelets that are getting us set up to create a blood clot, which is going to be our more stable way of blocking this hole that we've created in the blood vessel. The platelets also produce something called thromboxane A2, which is going to have a couple of different ways that it creates a positive feedback loop here, ultimately making this platelet plug bigger and tighter. Now, we don't want our platelet plug to totally close over a blood vessel, right? Like you don't want everything downstream from your blood vessel to get absolutely zero blood. And we don't want healthy tissue to get covered by platelets and platelet plugs. And later on, we're not going to want healthy tissue to get covered by blood clots either. So we need to prevent the spread of our platelet plugs now and those clots later on from spreading kind of out to the sides, which if we think about these platelets as being sticky and grouping together more and more, right, if we let that run away forever, they would eventually sort of start creeping up and down, I guess, this blood vessel. But we don't want to do that. So our endothelial cells in that layer of the blood vessel, the ones that are healthy, the ones that are undamaged, where we don't have exposure of the subendothelium, are always going to be producing a little bit of these two molecules. So we got prostacyclin and we have nitric oxide. And both of these are going to inhibit this process of platelet plug formation. Right. So here we got the picture of these things kind of going together, right? So here's our endothelial cell layer, right? So the endothelial cells are just the ones lining the lumen of our blood vessel. Okay. Our subendothelium is everything just kind of a layer out from that, right? So we've got subendothelium here containing collagen. I think that's probably why they drew it a little bit stripy, because collagen fibers kind of long, right? So this is that collagen that the von Willebrand factor would be contacting, right? So it's not on here, but this is where we would first see our von Willebrand factor sticking. before we have our platelets start to adhere, right? Okay. We're not mentioning the things that are further out in the blood vessel walls, but since we got an exam coming up, remember that we usually often have smooth muscle in blood vessel walls. Eventually, we'll get to some interstitial fluid and probably some tissue outside that. Might be more components depending on what kind of blood vessel we're talking about. Okay. So this one, given its smooth muscle, maybe we'll think of it as like an arterial, okay? All right, so we're touching this collagen, right? Von Willebrand factor activated this process, and we had some platelets adhere. So our first couple platelets, maybe think of them as those, right? And then we're making our platelet plug bigger. So think of this as in the picture, we got this platelet adhesion, and then we've got our platelet aggregation. So grouping together. And part of what's assisting us in grouping more and more platelets together are some of those secretions. So we have the ADP that they're secreting, making those platelets more and more sticky, right? Making this platelet plug bigger and bigger and bigger. And here we can see one of the roles of that thromboxane A2. Although if you've read this section in your book, you know that it has some more roles that it plays in the body, but this will be our most important one for us right here, is that it has this feedback loop where it's also kind of increasing this platelet aggregation piece. I've said the word positive feedback here, but I just want to point out for us that you notice that these are positive feedback loops, right? Usually we're talking about negative feedback. When we started with homeostasis way at the beginning of A&P1, we mentioned that usually when we are maintaining body conditions, when we're doing when we're regulating stuff, it's usually negative feedback loops. So that's usually our baseline guess. This is one of the specific kind of counter examples of where we see positive feedback loops in homeostasis, right? Keeping your blood in your body counts as homeostasis, right? Counts as maintaining internal conditions, right? So this is positive feedback loop. We have this change of starting to make platelets sticky, starting to plug something over, and we're increasing it, increasing it, increasing it here. So those are positive feedback loops here. Okay, so on the right-hand side, we see what's going on with our undamaged tissue, right? So here we see we don't have any collagen fibers exposed. We just have normal endothelial tissue lining the blood vessel wall, which means over here, we don't want any clots. We don't want any platelet plugs forming. We want to keep this blood vessel clear. It's not great when you have extra stuff sticking to the sides of a blood vessel wall. It's something we, in general, try to avoid, right? So here we see the prostacyclin and the nitric oxide coming out of that healthy endothelial cell. And we see that no platelets are aggregating together. So they'd if they were coming out of this cell, right, we might start to see that platelet plug go a little bit to the side as it grows bigger, but then it would be blocked over here. Okay. Questions about this platelet plug formation? Cool. In that case, just a quick question for you, because we're going to have a lot of words, a lot of chemical names we're learning here, and we're about to have a bunch of different clotting factors as we think about formation of a blood clot itself. So let's make sure we can tick off which of these things that we just mentioned is or isn't part of forming that platelet plug and, making the platelets adhere and making that platelet plug grow bigger. Okay, great. Yeah, our nitric oxide is what's blocking this. These other three components are helping us with this platelet plug formation or helping us with that initial adhering step for the platelets, right? The von Willebrand factor helps the platelets know where to go, helps the platelets stick initially to the blood vessel walls. And then ADP and that thromboxane A2 are doing our positive feedback, helping the platelets aggregate and form a larger plug. Okay. So we've done this vascular spasm to clamp things down. Now we've formed a platelet plug to try and cover over this injury site a little bit. But neither of those mechanisms are going to be enough to actually fully stop blood escaping here. The platelet plug does some good, but really we want to think of it as a precursor to forming a real, stable, better blood clot. Okay, so this is where we're going. We're going to try to form this kind of meshwork that traps some red blood cells, covering over that injury site better. Okay. So to do this, what we're talking about is clotting, but we're going to use the word coagulation, and we're going to be seeing some of these clotting factors or coagulation factors as we go through the next couple of slides. So what we're trying to do is create this kind of solid gel made of fibrin and eventually trapping some blood in there as well to plug over that hole. And formally, we're going to refer to that clot sometimes as a thrombus. Okay. So a thrombus is just the same thing as a blood clot. Yeah. So we have to form the platelet plug first because this clot is going to form around that platelet plug. It's going to form at the site of the platelet plug. And some of the secretions from the platelets are kind of helping kickstart this process. So this is really the most effective part of our injury repair, other than like actually healing the injury, right? But this is our dominant kind of mechanism here. Yeah. We're going to have a bunch of flowcharts and a bunch of numbered factors that we're going to be like slowly zooming out on. So I'm going to walk you through recommending what you should focus on first, and then what you should add on as you're studying and trying to learn this process. So you are going to see this pathway on all of our charts as we move through the next couple sections. So what we're trying to do when we make this blood clot are actual fibrin blood clot that's stable and is really helping us block blood loss. Maybe I'll uncircle that and do it actually backwards. All right, so the actual fully formed clot is this stable fibrin mesh. But to make that stable fibrin mesh, we're going to have to convert some proteins in your blood. Okay, so we're going to see kind of all the time in your blood, you have this protein fibrinogen floating around, okay? And we're going to notice when you see this inogen ending on terms, that often tells you that it's the inactive form of some protein, that it's ready to do something, but it needs to be converted before it's actually active. So that is the case for fibrinogen. We're going to need to activate that fibrinogen in order to ultimately form this big fibrin meshwork and our fully formed clot. At first, when we activate it, the first step of that process only creates a kind of loose fibrin mesh, right? So it turns the fibrinogen into fibrin, but these are strands. And so we've got some kind of loose strands, but we need to hold them together in a really kind of stable way. So a couple of fibrin strands on their own aren't really going to be enough to form a stable clot. We need to then bind those fibrin strands together, which is what the fibrin meshwork is. So we're thinking like, right, like some fibrin here, but we can see that we've also got these like cross connections and things to other fibrin strands. And this is another way you can look at it. As you can see, we've got something from someone else's textbook here, but here you can see that meshwork as well, right? What we're looking at is a fibrin meshwork. This is the stable mesh, right? Here we see the blood cells trapped in it, helping us form this blood clot, right? And we're going to be walking through our coagulation cascade. So all the different factors that need to be released and then act on each other in this kind of like snowball effect or like dominoes, kind of activating these proteins one by one. Okay, so we're going to zoom out a little bit, right? So we've mentioned we're trying to get to this stable fibrin mesh, right? And to do this, we had our inactive fibrinogen. That's why it's pale here, right? So fibrinogen is our starter molecule. First, we converted it into a kind of loose meshwork, so looser strands before we stabilized it. Right, so that's from the previous slide. Right? So this is the first thing you want to remember and get into your minds as you're studying. But the next step you're going to want to get into mind is like, how do we do that? Right? So how do we convert the fibrinogen into fibrin? And then what is causing this stabilization of the meshwork? So our next most important piece to remember here is going to be this clotting factor called thrombin. Okay. Now you'll notice we have Roman numerals throughout this in a lot of places. Unfortunately, they're not numbered in the order that we have to activate them. I think they're numbered in the order that they were discovered, which is not so helpful for us. Some of them have like common English names, right? Like not like common, right? But you can call this thrombin. People do call this thrombin, but it is also technically clotting factor 2A. So that's what that means when it says that below it. Okay. So thrombin is really important, right? Our next most important thing to remember, other than fibrinogen to loose fibrin to stable fibrin, because thrombin is key to both the initial conversion of the fibrinogen and then also its stabilization. Right? So you can see this direct role it plays, right? So its direct role here is that thrombin is the clotting factor that turns fibrinogen into fibrin, right? So it's directly acting on this step, right? It's also indirectly responsible for the stabilization of that fibrin mesh, right? So you can see it's not directly what's converting this looser fibrin to the stabilized fibrin, right? Directly responsible is this factor 13, right? But thrombin is the thing that activates factor 13. Like, as you can see, we gotta activate pretty much everything that's in this pathway, right? So what's happening here in order to stabilize the fibrin is we've got inactive factor 13 floating around. Once we have thrombin in its active form around, it can activate factor 13, usually kind of at the same time as it's turning fibrinogen into fibrin. And then factor 13, once activated, stabilizes the fibrin. So in order of priority of remembering things, we want to remember this fibrinogen to fibrin to stable fibrin pathway first. Then next thing I would focus on is this role of thrombin here. We can see that thrombin's also doing some other stuff, and we can also see that thrombin itself came from somewhere. Okay, so let's think about where the thrombin is coming from and the role it kind of plays in that pathway too. So we know we need thrombin to activate our fibrinogen. We also had to activate thrombin in the first place. So we can see that thrombin's inactive form was something called prothrombin, right? So prothrombin ultimately becomes thrombin when it gets activated. And what activates it, kind of more directly, is another clotting factor 10, right? So this clotting factor 10 turns prothrombin into thrombin, okay? And then thrombin can act on this clot itself, form the clot itself, both directly and indirectly acting in these steps. Yep. Once we've activated a little bit of thrombin, in addition to working on that meshwork that we see at the bottom of the slide, we also have another positive feedback loop. There are a lot of positive feedback loops in clotting. So a little bit of thrombin is going to loop back up and activate factor 10, right, which had an inactive form. And we can see it's also interacting with something called our intrinsic pathway here that we'll talk about in a little bit. Okay. So what I recommend for learning this stuff is drawing flowcharts yourselves, but I recommend focusing first priority on this. Kind of second priority would be this step. And then remember that factor 10 is the one that's activating the thrombin here. So those are the parts I would consider kind of most important. And the order, at least, I would kind of recommend learning them in, although if it makes more sense to you to start at the top, if it works, it works, don't mess with it. Okay. But we are going to zoom out some more. Okay. Before we do that, let's make sure that we know the order that things have happened so far when we're thinking about those platelets and we're thinking about the fibrin, right? Okay, let's take a look. Okay, yeah. So we had our platelets adhering first, so platelet adhesion, sticking to the wall of the blood vessel. Then they aggregated, so they formed a big group. And then we got to this formation of the fibrin clot. Cool. Okay. So now we have the zoomed out picture, right? So we've talked about converting fibrinogen to loose fibrin and then stable fibrin. We talked about the fact that thrombin plays a really heavy role in this, right? So we have thrombin that came from this inactive form, prothrombin, right? And we know that factor 10 was one of the big things that's helping us activate thrombin so that we can really make this clot. Yeah. No, we got some other things in here, right? So that factor 10 has some helpers. So it's got another factor involved here. It's got some calcium involved in this. This PF3 is a platelet factor, so platelet factor 3. So while I know while this flowchart can seem kind of intimidating, there's a lot of stuff in it. There'd actually be even more pathways to link together if you wanted to really fully go through absolutely all of the clotting factors and their roles. Okay, so we're going to take a look at them piece by piece, but we're going to see that we have an intrinsic pathway coming in here to help us activate factor 10. And we also have an extrinsic pathway that does the same thing. So they're working together. Both of them are kind of funneling into the same place, activating factor 10, which is why when we're thinking of numbered factors, the one I'd like you to remember is this factor 10. Okay? because this is kind of the joining point for our two pathways here. Okay, so here we have our intrinsic pathway. Okay, so when we say intrinsic, what we really mean is that this is getting started off from factors that are activated right at that site of injury, like by the blood vessel itself. So this intrinsic pathway is starting because we have a factor that, like von Willebrand factor in the platelets, gets activated when it comes into contact with collagen. So we saw that collagen in the subendothelium. That is also part of this intrinsic pathway, getting us ultimately towards our stable fibrin clot. Okay. So here we can see that we have this domino effect of clotting factors getting activated after that first one, right? So that first one that starts off our intrinsic pathway is factor 12, right? So factor 12 is getting activated. And then in turn, it's activating factor 11, then factor 9, which ultimately activates factor 10. Okay, cool. All right. So I wouldn't put a ton of effort into memorizing all these intermediate numbered factors up here, but you should know that they exist, that this is how our coagulation pathways work, because depending on where you head after this class, you may have to very thoroughly memorize and learn about coagulation pathways. So wouldn't be doing my job if I didn't let you know that there's all this out there to learn and all these different steps that could potentially go wrong, as we'll mention in a second. But before we do that, right, in addition to this intrinsic pathway, we want to know that there's an extrinsic pathway. Okay. So the extrinsic pathway is activating tissue factors. So what that means is, like, if you damage something in your arm, you've got skin you damaged on the way to the blood vessel, you've got probably some fat, you've got muscles maybe, right? You went through different tissue types on the way to the blood vessel that got damaged. Even if that damage comes kind of from inside, say your blood vessel got damaged by like crushing, or your capillaries burst from too much pressure or something, they probably damaged some tissue around the blood vessel as well. Relatively uncommon for just the blood vessel and nothing else to be damaged. Okay. So that damaged tissue around the blood vessel also sends out signals that say, hey, we've got damage here. We need to stop this escaping blood. Okay. So here we see one of those tissue factors, right? So we have this active tissue factor happens to have the number 3, and this inactive factor 7 coming together with some calcium to form a larger tissue factor complex that we call the tissue factor 7, and then the A is for active complex, right? For our purposes, I don't need you to remember all of those numbers, but I do want you to know that we're activating some tissue factors because tissue got damaged, and that they're combining to ultimately help activate factor 10, which is also where we have our intrinsic pathway coming in from the blood vessel wall itself. And ultimately, we care about this factor 10 because that's helping us activate thrombin so that it can form the clot. Okay, so here we see that intrinsic pathway popping on as well. Here we see that factor 10, once it's activated, turning prothrombin into thrombin. And then that thrombin gets to turn our fibrinogen, which isn't a clot, it's just in the bloodstream right now. But once activated, it's going to become this fibrin meshwork. First a little loose, but then we have this indirect action of thrombin as well, where we've got another little domino step, right? So thrombin had to activate factor 13. And factor 13 stabilize that fibrin meshwork. So questions about this process at this point? I personally think it's a lot when someone's just saying it to you or when you're reading it in the book. I don't know, my brain gets a little bored with all the things that are named with numbers. Highly recommend kind of drawing out these pathways for yourself as you're working to get them into your minds. Okay. So since we just talked about them, what was it that we want to remember about our intrinsic and extrinsic coagulation pathways? Mm. Okay. Yeah. Okay. So we want to know that ultimately they're both flowing together into the central step that keys in on factor 10, which is ultimately going to let our thrombin convert fibrinogen to fibrin. Okay. For the second most popular answer, right, the tissue factors are just coming from that extrinsic pathway here, right? Not the intrinsic one. The intrinsic one is getting activated because of the contact with collagen, okay? And they're both kind of happening at the same time to actually form the clot rather than kind of inhibit or control the edges of the clot. Okay. So some notes separate from this big flow that we just went through of our blood clots. So we also want to know that these clotting factors, like prothrombin, like fibrinogen, but also like that inactive form of factor 10, and all those other inactive forms that we saw in that flow chart, right? Like factor 12, factor 13, right? It's your liver's job to make them. And they are swimming around in your bloodstream right now, even though hopefully right now you're not forming any clots, right? We just need to activate them, and they're activated by like the actual damage to the blood vessel and to the tissue. At least that's how it's supposed to work. Right. So they're generally, we think of them as being in the plasma, right? So in that part of our whole blood, it makes 55% of it, doesn't contain actual blood cells. If we wanted to pull out just those clotting factors, which sometimes we do, right, the part that's left over, the plasma that doesn't have any clotting in it, would be called serum, okay? So if you hear blood serum, that means we removed all these clotting factors so that serum doesn't have the possibility of creating a blood clot if you give it to a new patient. Okay. And there are other substances that we need for clot formation other than the ones that we just went through and other than the ones that I'm telling you to prioritize. So we're going to need calcium ions. They're going to interplay with factor 4. We're going to need some platelet factors. I did point out that we had that PF3 somewhere on our map, right? So platelet factor 3. So some of those secretions from the platelets that they're secreting during that platelet plug formation do play roles in this blood clot formation. And that's part of why that platelet part had to happen first. Yeah. We do have things that limit blood clot formation as well. So in general, if we have something that's stopping you from clotting, right, or preventing clotting, We refer to it as an anticoagulant because coagulation is that clot formation. So anti, opposite of clot formation. So you have proteins in your plasma that act as anticoagulants, and you have things on the surface of the endothelial cells, the healthy ones, that also act as anticoagulants. Kind of just the same as when we were looking at the platelet plug inhibition by the nitric oxide and the prostacyclin. Okay. So among these, we have a tissue factor pathway inhibitor. So this tissue factor pathway inhibitor is called a tissue factor pathway inhibitor because it's acting on that extrinsic pathway. And that extrinsic pathway was the one where we have injured tissue releasing tissue factors. Okay? So that's one of the things you see coming out of healthy endothelial cells. They'd be saying, hey, we get this signal from the tissue. We don't want to pay attention to it because actually we, the endothelial cells, say this blood vessel is fine, right? So you wouldn't want, for example, injured tissue to be sending out this signal not only to the blood vessel that's damaged, but also neighboring blood vessels that are fine, right? You just want the clots forming in the right spot. We also have something called thrombomodulin that acts as an anticoagulant. So again, this is coming from healthy endothelial cells. What this does is that in those healthy blood vessels, those healthy endothelial cells secreting this thrombomodulin are going to bind on to the thrombin. So the thrombomodulin and the thrombin come together to form this complex, this thrombin-thrombomodulin complex that activates another protein in your blood, protein C. And this whole stuff together acts as an anticoagulant. Protein C acts as an anticoagulant. And when thrombin is bound to thrombomodulin, it can't work correctly for blood clot formation. So if it's bound to thrombomodulin, it's already busy and it's not going to be converting prothrombin into, it's not going to be converting fibrinogen into fibrin. Okay. All right. So when we have a blood clot, that's great. We're blocking blood from escaping through this hole in our blood vessel, but we don't want blood clots to hang around forever, right? We want the blood clots to stop blood loss, and then we want the tissue to heal, and we want the blood clots to go away, right? That's our actual goal. So we also need to know about breaking down those blood clots, right? Because this is a temporary measure. So in order to break down our fibrin clot, the thing that we're going to use is called plasmin. Okay, so plasmin is going to work as an enzyme to break down fibrin, right? So it's another protein from your bloodstream. Okay. In order to have plasmin acting as an enzyme to break down your fibrin clot, it had to be activated. So its precursor is plasminogen. So this is our inactive form. Right? So this is kind of why I'm giving you the heads up that when you see this inogen ending, right, we'll see this also when we talk about the digestive system. Inogen on the end of a protein name tends to mean it's inactive. Okay. So we need to activate that plasminogen to its active form, plasmin, that acts as an enzyme to break down this fibrin clot. So one thing that we have happening is we have something called tissue plasminogen activator. Again, this is secreted by endothelial cells, but in this case, it's being secreted by endothelial cells during this clot formation itself. And actually, the fibrin clot itself, kind of as it's forming, is helping to start off this pathway to break itself down, right? So the fibrin itself is helping ultimately to activate plasminogen and turn it into plasmin to help us destroy the clot after it's big enough, after it's formed, when we're ready to do that. And there's a lot of kind of interplay in all these pathways. It's kind of the sense we want to get here. Okay. When we think about these coagulation pathways and these blood clots, we may know that there are various clotting diseases that can affect how people respond to injury, for example, right? So a particularly famous one is hemophilia, right? So hemophilia is a genetic disorder. But if you have hemophilia, uh, even really small cuts can be potentially life-threatening because you don't form a blood clot to close over that injury. So you just bleed and bleed and bleed. So it makes it really easy to like bleed out, right? To have kind of runaway hemorrhage. So what hemophilia is doing is we have a deficiency in a gene that codes for one of our coagulation factors. Now, it's not one of the coagulation factors that I highlighted for you as particularly important for us to remember, but I have circled right here which one it happens to be. So one of the coagulation factors that hemophilia has impacted is this factor 8 here. So you can see that this factor 8, right, it's part of this end of our intrinsic pathway, right? So when we had that intrinsic signal from a blood vessel ultimately telling us to activate factor 10 and ultimately make a clot, right? It's interacting with this factor 8. Right, so hemophiliacs don't have a functional factor 8. This is part of why they don't really form effective blood clots, right? It's not exactly the only thing that's going on there, but that's one of the major things. Some less famous clot formation disorders include von Willebrand's disease. So von Willebrand's disease reduces the levels of von Willebrand factor. So we've primarily thought about von Willebrand factor and its role in the platelet plug formation. And we know that we have to form that platelet plug in order to kind of start off this clotting. That's important in this pathway. Von Willebrand factor does also have some role to play in some of these clotting factors itself. Third one is like a disease, but not a genetic disease, not an infectious disease. It's a deficiency, right? So if you don't have enough vitamin K, whether it's because you don't have enough of it in your diet or for other reasons, it affects your liver overall, and it affects the creation of all of these clotting factors, basically. As your liver is making clotting factors, it uses a bunch of vitamin K. So if you have a vitamin K deficiency, you're going to have trouble with clotting overall. Our final piece of the picture here and our final clinical note is going to be about aspirin. So you may know someone or have heard of someone who has a history of like heart attacks and is told to take baby aspirin every day, or maybe they tell you to do that in response to strokes too. I don't remember off the top of my head. When you get told by your doctor to take a baby aspirin every day, what they're actually trying to do is stop clot formation. Heart attacks are often caused by clots getting stuck in little arteries that feed your heart muscle itself. Strokes are caused by clots getting stuck in blood vessels in your veins, or sorry, in your brain. So you don't want that to happen, right? So if you have too many clots forming in your body and your doctor knows that, they may tell you to take aspirin, but more aspirin is not better, right? This is one of those dose-dependent things. You want it to be a really low dose of aspirin because at a low dose, aspirin acts as an anticoagulant. People sometimes refer to it or think about it as a blood thinner, but what it's actually doing is it's inhibiting early parts of this clotting process. So what it does at these low doses is it inhibits the formation of this thromboxane A2. So the thromboxane A2 was one of the secretions from our platelets, right? That has many roles, including doing positive feedback, creating a larger and larger platelet plug in this platelet aggregation process. So if you don't have thromboxane A2, you probably still form a platelet plug, but it's going to be a little harder. It's going to be a little smaller. We're going to inhibit some of this clot formation, right? It's not going to run out of control in quite the same way. Unfortunately, if you get the dose wrong, right, it's important to listen to dosages because at higher doses, aspirin has a different effect, right? So it might still be acting a little bit on the thromboxane A2, but at high doses, it's going to impact our formation of prostacyclin. And we want that prostacyclin because the prostacyclin was coming from our healthy cells saying, hey, don't form a platelet plug here, right? So if you inhibit the formation of prostacyclin, that makes it harder for healthy parts of your body to avoid forming clots. All right, so we're at time and we're at the end of the packet, so we'll end here. Hope everybody